Hello everyone, I'm going to present my case study titled Exertional Dyspnea in a 76-year-old Man. His chief complaint was shortness of breath. He presented with a history of a 6-month period of difficulty breathing during exertion with occasional substernal chest pressure. He denied radiation of the chest pain, nausea, and diaphoresis. He endorsed lower limb edema. His past medical history includes hypertension, hyperlipidemia, type 2 diabetes, end-stage renal disease on dialysis, and left knee replacement. He has no known allergies. He is currently taking lisinopril 10 milligrams once daily, atorvastatin 40 milligrams once daily, insulin, glargine 50 units sub-Q daily, calcium carbonate 500 milligrams twice daily, darbepoetin 40 micrograms IV weekly. His father had hypertension and stroke, and his mother had type 2 diabetes. He is married and a retired teacher. He denies tobacco, alcohol, or illicit drug use, denies shortness of breath at rest, orthopnea, or paroxysmal nocturnal dyspnea, denies any episodes of palpitations, lightheadedness, or syncope, denies any cough, fever, chills, or night sweats, denies weight changes, rashes, skin lesions, vision changes, ear pain, nasal congestion, discharge, sore throat, abdominal pain, nausea, vomiting, or changes in bowel habits. He does endorse fatigue. He has not produced urine for several years since beginning dialysis. He denies missing dialysis treatments, denies redness or pain in extremities, endorses increased swelling in his feet and ankles, denies neuro and psych symptoms. Physical exam was unremarkable, except his blood pressure was 155/86. He had jugular venous pressure 5 centimeters above the clavicle at 45 degrees and delayed carotid upstrokes. The cardiac exam was abnormal with a crescendo, decrescendo, systolic murmur heard best at the right upper sternal border radiating to the carotids. There were no rubs or gallops. In the extremities, he had 1+ pitting edema to mid-shin bilaterally, no tenderness or erythema. He also had 1+ dorsalis pedis pulses bilaterally. Dialysis graft present on his right forearm had a good thrill. So based off this information, the top 3 differentials were acute decompensated heart failure, which can cause dyspnea on exertion, chest pressure, and lower extremity edema. Also aortic stenosis, which can cause dyspnea on exertion, chest pressure, and crescendo, decrescendo systolic heart murmur. And lastly, volume overload from end-stage renal disease, which can cause symptoms of volume overload, including dyspnea on exertion, chest pressure, and lower extremity edema. It was determined that he had severe aortic stenosis. The treatment plan for this diagnosis includes referral to cardiology to evaluate for surgery for aortic valve replacement. Aortic valve replacement effectively treats symptoms and should prolong his life. He does not need to be admitted to the hospital for emergency aortic valve surgery because he is considered to be stable with normal vital signs. Up-to-date notes that those with frank heart failure, angina, and syncope should be hospitalized while waiting for valve replacement. Patient education includes counseling about the expected disease course, treatment options, and end-of-life preferences. He should engage in only mild physical activity, as his symptoms will be exacerbated by even moderate physical exertion. The treatment of his hypertension is also recommended. According to UpToDate, diuretics, beta blockers, and vasodilators should be avoided. Diuretics reduce preload, which the patient may depend on for the maintenance of cardiac output. Beta blockers reduce contractility, which may pose a risk for the overloaded left ventricle. And then vasodilators may reduce systemic blood pressure and reduce coronary artery perfusion. So because of this information, ACE inhibitors are the preferred treatment and are well tolerated in these patients. UpToDate also recommends optimal preventative care, and this can prevent any hospitalizations. And this includes the pneumococcal vaccine, annual influenza vaccine, and routine preventative care examinations. For follow-up, he should be reevaluated after surgery and once he's stable every 6 to 12 months or sooner if his symptoms worsen. It is also important to assess for the development of symptoms and any changes in exercise tolerance. And then we want to be doing echocardiograms yearly to assess for evidence of progression. Moving into the pearls of wisdom, I just wanted to reiterate that my top 3 diagnoses were the acute decompensated heart failure, aortic stenosis, and then the volume overload from end-stage renal disease. And I'm just going to talk through my thought process into eliminating 2 of those differentials and then deciding that aortic stenosis was the diagnosis to go with. So for acute decompensated heart failure, this can present with the dyspnea on exertion, chest pressure, and then the lower extremity edema, symptoms that this patient did present with. The dyspnea and heart failure is caused by increased pulmonary venous pressure, which can cause hypoxemia and then low cardiac output. Heart failure can also cause paroxysmal nocturnal dyspnea, orthopnea, and symptoms tend to resolve between episodes, all of which this patient did not have, thus not supporting this diagnosis. Diagnostics include the ECG, BNP, chest x-ray, and an echocardiogram. This patient had a normal chest x-ray. The ECG did show some left ventricular hypertrophy, which can support the diagnosis. The ECG, the BNP levels were also high, which can support the diagnosis. But the echo showed normal ventricular size, normal ejection fraction, and then the severe calcified aortic stenosis, which to me would confirm that there was some heart failure going on, but the aortic stenosis is the main diagnosis for this patient. The volume overload from end-stage renal disease, that one can also cause symptoms of volume overload, including dyspnea on exertion, chest pressure, and lower extremity edema, all symptoms that this patient presented with. This patient was also anemic, which is a common manifestation of end-stage renal disease. These symptoms are caused by hypervolemia and volume overload secondary to the kidney's inability to process excessive fluids in the body. His respiratory and cardiac exam did not show any signs of cardiopulmonary overload. And we also know that he didn't miss any of his dialysis treatments, making this differential unlikely. And then moving to the actual diagnosis of the aortic stenosis, this can present with dyspnea on exertion, chest pressure, and the crescendo-decrescendo systolic heart murmur, all of which this patient did present with. Exertional angina is also common with this diagnosis, and this patient did have the exertional angina. These symptoms are actually caused by diastolic dysfunction and the inability of the left ventricle to pump out enough output during exercise. Other common findings include slow rising carotid pulse, the mid to late peaking systolic murmur in the right intercostal space, and a single second heart sound, all of which this patient exhibited. An ECG and chest x-ray are typically not warranted. An echocardiogram is the gold standard for diagnosis. To diagnose severe aortic stenosis, this is defined as a valve area of less than or equal to 1.0 centimeters squared, an aortic velocity of 4 meters per second or higher, and then a mean transvalvular gradient of greater than or equal to 40 millimeters of mercury. This patient met all of this criteria, thus confirming the diagnosis, and then in addition to the other symptoms that he presented with. I thought this was a great pearl for aortic stenosis. According to the American Family Physician, in symptomatic patients with an echocardiographic measures consistent with severe aortic stenosis, symptoms must be presumed to be a result of aortic stenosis, even if other potentially causative conditions such as cardiovascular disease are present. Thank you for listening.